Good morning. Great to get a response. Thank you. So it sounds like a moderately awake crowd, which is great. I have the pleasure this morning of introducing the first IHPI Emerging Scholar that we've invited, who I'm so glad was willing and able to join us. Dr. Kit Delgado is an assistant professor of emergency medicine and epidemiology at the University of Pennsylvania. The broad themes of his research are innovative approaches to improving outcomes for the acutely ill and injured. I'll let him talk more through some of the specific projects he's done that fit that theme. He did, before his current position, he did residency and a Master's of Science in Health Services Research at Stanford University. He did extensive training in secondary data analysis there. And prior to that, he did his MD at Columbia. So thank you so much for joining us, Dr. Delgado.
All right. Well, thank you for having me here. So I'm an emergency physician by training and do injury research, both on prevention and health services research. For me, this is almost like coming home. So the last time I was here was in September, and I was here. Rebecca Cunningham's group put on a great injury conference, the highlight of the conference for me was actually kicking a field goal through uprights at the big house. And I grew up a Michigan fan because it turns out that the last time I was here before that, I was in the womb. My parents met here when my dad was a postdoc, and my mom was a clinical fellow. So it's good to be back. I work in the emergency department about 1, maybe 2 days a week in a level 1 trauma center in inner city, West Philadelphia. And as many people before me who are interested in public health have called it, the emergency department is a room with a view. And the reason we say that is that if this is a great piece in the New England Journal in 2011 by Art Kellerman and Rick Martinez, who said that the quickest way to assess the strength of the community's public health, primary care, and hospital systems is to spend a few hours in the emergency department. And so that, for someone who's interested in public health, you really see where everything breaks down. And so most of my initial work and a lot of my ongoing work is around organizing care to better take care of those patients. But sort of the more and more sort of tragic stories that you come across and become more and more motivated to prevent them from getting there. So, a couple narratives from patients that I've treated that inspire this work. The first would be I had a 21-year-old Temple senior who's driving down the highway to come and pick up his girlfriend after a shift. He heard the ping of his iPhone go off. He leaned down to get it. Next thing you know, he smashed his card into the guardrail. And here's a guy who's going off to Wall Street, very smart guy, and couldn't do his finish his finals because he was so concussed afterwards. And so it's a behavior that's happened right before we got there, and I think we have some solutions to prevent that. Alcohol-impaired driving crashes we see all the time, and then the last one sort of sticks in my mind is we probably get at least one heroin overdose a shift now, and one of my recent ones is a 23-year-old guy who's been using heroin off and on for the last 2 years. It started when he was riding his bike at the Jersey Shore and went over the handlebars and broke his wrist and got 60 Percocets, and he really liked the way it made him feel, and he after those ran out, he started getting some from friends, and then when he told me that it was harder and harder to get, and then he started injecting heroin. So I'm going to talk a little bit about how to prevent these things. So I've been on faculty for a couple of years now, and have launched our new lab, which actually the website's sort of now live. It's still a little work in progress. We call it Be Safer, Behavioral Science and Analytics for Injury Reduction. And the mission is to apply behavioral and data science for preventing injuries and better taking care of them once they occur. Most of my funding right now is in the injury prevention side of things. So I have a K award and a federal cooperative agreement aimed at applying behavioral economic approaches to reduce cell phone use while driving. I have some pilot funding aimed at reducing alcohol-impaired driving, and then been spending a lot of work recently on behavioral economic approaches to encourage safer opioid prescribing. I still do a lot of emergency, like more traditional emergency care and trauma care, health services research. I have an RO3 looking at trauma outcomes in New Jersey, dependent on whether you go to a trauma center or non-trauma center, using instrumental variable approaches. And then I collaborate on a lot of other people's RO1s related to emergency and critical care. So going to the issue of behavior change, I think you've probably seen some of this with people that work here and people who have come to visit. But traditional classical economics and traditional behavior change models assume that if you inform people about the risks of something that you get them, they'll act in their own best interest. So sort of this is like who I think about. It's like you tell someone that it's dangerous to ride a bike, you'll wear a helmet. Behavioral economics takes insights from psychology to explain why people consistently do things that are not in their best interest, and sort of think about these guys who are having fun, but it's like they're probably less extreme examples, but it can predictably show why people don't act in their best interest. I like this slide because it gives a nice overview of the field of behavioral economics. So most sort of thinking is heuristic, and it's called System 1 thinking. That's from Danny Kahneman's work, who won the Nobel Prize. Whereas System 2 thinking is when you sort of slow down in the medical field. You might think about guidelines and decision rules and very sophisticated cost-effectiveness analyses. We know that because of these different biases, present bias, the people who tend to value things that are more immediate versus things that are potentially bigger rewards or in their best long-term interest. Status quo bias, which is whatever the default is, you're most likely to stick with that. These are things that consistently affect our behavior, and we can either let them not let us change behavior for good, or we can take advantage of them to get people to change the behavior for good. All right, so I'm going to apply this to motor vehicle crashes. So in the issue of cell phone use while driving, and despite numerous laws that exist in pretty much everywhere in the country, a lot of public awareness campaigns, distracted driving crashes continue to increase. You have this, if you go to YouTube, you can find the video taken by the couple that was traveling behind this guy, who saw him swerving across the lanes of the highway while he was engaged in a texting conversation, and then plowed and killed all 13 people on this church van. If you look at the data over here, the National Highway and Traffic Safety Administration documented that even though we made tremendous progress in reducing motor vehicle crashes, 2015 they started going up. And the biggest contributing causes to the increase or distraction-affected fatalities, but you also have alcohol-impaired driving fatalities and speeding fatalities. And these are all things, I think, that behavioral economics and new novel approaches can have a role in addressing. Some of the earliest work looking at the effect of the implementation of texting while driving bans actually showed an increase in crashes. Anyone think about why that might be? So if before there was no adverse consequences to, texting and driving, and you have your phone out here, you're kind of looking on the road, and you're, looking here, there's no problem. But now that you can get nailed with a ticket, people hold it down here, and they're taking their eyes off the road longer, and that's sort of the common pathway to getting in a distracted driving crash. So what do we need to design around? So there's some literature on this, or the underpinnings here. On the left is an experiment where they asked people who texted while driving frequently and compared to controls who did not, to do a delayed discounting task where you ask people would they rather take a smaller amount of money now versus a larger amount of money in the future. And what they show is that people who text while driving frequently have steeper discounting curves, and that's sort of a hallmark of time and inconsistent preferences or present bias, and so that's one aspect. The other is availability bias. I guarantee you that probably half of the people in this room check their phone while driving at some point in the past month, but probably none of you got in a crash, and sort of based on your available experiences, you said, this was okay, nothing happened, and sort of that sort of because of your direct experience and not having had a problem, you continue to do it. There's also overconfidence bias, so that's sort of saying that I'm actually really good at texting while driving. I can, and where the objective evidence says that, well, even if you're taking your eyes off the road, you're probably still at higher risk for a crash. And there's status quo bias. So that means that in our default way our phone works, every single Facebook, Instagram notification, every single phone call from a parent to a teen, all that stuff's going to come through, and you're not going to do anything, even if there's settings available to turn like airplane mode or do not disturb while driving. You're not going to act on those unless you're nudged. And then finally, social norms. So like if my wife sends me a text and I'm not at work or at a shift, she kind of expects that I'm going to be writing back within 5 minutes. And that's a common social norm. And for teenagers, it's like, you better write back in 30 seconds or else you're not my friend. And so, what can we do about it? So this is from the UK Behavioral Insights team. They took used insights from behavioral economics to redo government policies, and we're the first sort of nudge unit or behavioral design team. And it's been replicated now in our health system and other places. But they have this crafty mnemonic called Mindspace for behavioral insights and how to translate those into behavior change. The first is the messenger, so M. So if a message is coming from like a celebrity or someone that you trust, you're more likely to act on it. Incentives have been shown to be very powerful, particularly for people who are present biased and want to get some sort of immediate reward right away. And it's been shown that people value losses twice as much as gain, so if you frame it with a loss format, that's going to be dollar for dollar more effective. Social norms are pretty important, and you can change behavior just by affecting what the influence of the perception of what others do. Defaults, so this gets around status quo bias. So in countries that where you have to opt out of organ donation, the organ donation rates are like 90% versus ones where you have to opt in. It's the organ donor rates, or people who register as organ donors, is like 10%. So let's start. Salience, people are influenced by incentives that are new. And so every single experiment in healthcare that sort of made your insurance premium contingent on your health or your behaviors never works, because it gets folded into something that you don't really see. So drawing out that incentive and making it more salient is more likely to make it more effective. And there's some other ones here. Commitment, getting people to take up commitment devices, because because they know that, like for example, if you know that you're having difficulty getting up in the morning and you keep on hitting snooze, you can get an alarm clock that basically it like starts running around the room when it goes off, and you have to like get it and go turn it off. All right, so now into the research. I became interested in cell phone use while driving as a sort of model behavior to test behavioral economic interventions with one, because it's something we can actually measure in real time pretty well. So there's a company, sort of one of the earliest companies called Cell Control, that makes this device that's like an easy pass, which you can put on your windshield. It's solar powered, it's got a GPS and accelerometer, it pairs with your phone, and it can basically, in the app on the phone that you download, basically collect a time series of all your phone use, and then it's combined with the speed and GPS coordinates of your travel. And you can also have it and set different settings to like limit your not being able to unlock your phone, blocking text messages, sending automatic replies. And so we connected this with our web-based platform called Way to Health, which we've used for a lot of different studies, more typically with things like Bluetooth pill cap monitors, weight scales, and pedometers and things like that, which our Center for Health and Science and Behavioral Economics has done a lot of studies with to study this issue. This particular device has like a sensor to tell whether the phone is in the driver's seat or passenger seat, so to sort of classify whether you're using your phone as a driver or passenger. This is some of our earliest sort of pilot data from a teen driver participant. At the top, let's see here. These blue lines right here are the speed of the car, and this is at time, so like a 20-minute trip. And at point A, we can tell that the phone was unlocked, and it was unlocked for this amount of duration. And because we had the GPS coordinates, we can tell it was on this type of road. They drive along, and then they unlock their phone a little bit higher speed, and we can tell it's a more downtown area, perhaps more high risk. And so we have some ongoing studies where we're linking the GPS data with sort of things about the built environment to gain a better contextual understanding of what's going on. So our first pilot randomized control trial, we enrolled 16, 17-year-olds by sending an email or a letter out to parents who we knew had 16 and 17-year-olds, and they would enroll online. They text us a picture of their driver's license. We mailed them the device. They downloaded the app, and for the first 4 weeks, the app just ran in the background, and we just sort of measured like what their natural behavior is. After 4 weeks, they logged into our web-based platform. They got shown a scary video of someone who died in a texting while driving crash, and there's some web-based content there. And then there was a control group who followed, just continuing to be monitored. There's opt-in blocking. So this is like when you get on an airplane and you have to turn on airplane mode. You have to turn on the app. And once you turn on the app, it sends automated text messages to people who come in. It silences your notifications. If you want to pick up and use your phone, you have like a safe mode screen, but you can, at the top, there's a button where you could turn it off, and it turns it off for the duration of the trip. The opt-out blocking basically is the same, except the sensors detect when you're driving, so it just comes on automatically. And then you can opt out of it at any time by hitting the button at the top. And then with notification, it's the same, but if you override the blocking function, it pinged your parent with an email. All right, so this is from our baseline period. So for these 35 drivers, we tallied up over 2,000 incidents of them unlocking their phone screens while driving, and about half of them are more than 25 miles an hour, with a quarter more than 40 miles an hour. was sort of like, wow, this is kind of alarming. And then when we looked at the results of our intervention, on the y-axis here is minutes of non-call time per hour of driving. So that's like they're unlocking the phone, using their phone, but it's not for calls. And here are the intervention groups. The light blue bars are the control period, and the blue bars are the intervention period. You see in the control group, now these are small numbers, but the control group, it increased. So on average, even in the intervention period, people were using it on average 12 minutes of the 60 minutes that they were driving. It went up a little bit in this group, but we saw fairly dramatic reductions that even in the small trial were statistically significant for both the opt-in blocking and opt-out blocking, despite having sort of different baseline rates. When we looked at talk time, sort of the other thing that jumped out at me is like, well, teens aren't really talking on their phone all that much. It's really for other stuff. So, a lot less, but, across the board, they either got a little bit better or, pretty much, reduced almost completely here in these groups. So we're excited. We presented this at this injury conference. It's under review right now. We also did a follow-up survey with a couple hundred teens to ask them about barriers to reducing this behavior. And we asked them specifically, which of these following uses of your phone you're not willing to give up while driving? And basically, and this is kind of important for acceptability, functions of the phone that we all use, like for navigation and music, that are really just an extension of the car, people are not willing to give up. And that's not really impulsive behavior, it's just it's a different thing. So that's a nuance that we picked up. And then there's the whole adoption and the cost issue. So, people who, it took us like 3,000 letters to enroll, 35 people. And people aren't going to go out there and buy this technology, especially if they have to pay money for it. And it's an extra hassle. So how do we design around that? So the other thing we asked them is, of a menu of these different interventions, which do you think would be, most promising? So we asked them what would be very effective for reducing cell phone use while driving. The dark blue bars are people who are texting a lot, and the light blue bars were ones that were texting less frequently. The ones who, so the most popular was individual financial rewards, and then followed by other types, frame, like loss framing, group-based rewards, and importantly, things like even an automated text response or, the sort of status quo of parents saying, don't do this. It was not perceived to be very effective, and there was some differential effectiveness perceived by whether you used it a lot. So the highest risk group are not likely to, at least they say they're not likely to respond to the status quo interventions. So here's what I think is promising. So how many iPhone users here? So did you guys remember in September you might have gotten an active choice about whether to activate Do Not Disturb while driving? And you probably had that one-time thing. Some of you maybe did, some maybe didn't. But that's like a big potential because now you have, like that millions of people in the US who can have most of the same capabilities of that expensive device being exposed to this intervention. But if you use it, it can make a difference. So, it basically, if you try to use your phone, I don't know how many guys actually have it, so it comes on. So, if you try to use your phone, you have to hit a button that says "I'm not driving," and then someone texts you a text and automated response. So that's one way of sort of limiting the temptation to use your phone on a wide scale. But I think what's even more exciting is that now the technology has gotten so good and machine learning has gotten so good that there's standalone smartphone applications that can actually, with 90% accuracy, tell if you're driving, just based on how the phone is being used, the sensors, even like the rotation into the car, the rotation out of the car. And so, for example, it's a company we work with now called TrueMotion. This is like one of my trips. I did this just to generate cool data for a talk. But here, the phone, I'm tapping on the phone, and then I stop tapping on the phone. And they do it based not just on phone screen unlocks, but actually like typing and swiping on the phone, so it's active use. They don't count things like if GPS is streaming in the background or music is streaming. But also by linking your speed of travel based on your GPS to the posted speed limits, you can also tell if someone's speeding and by how much. And these are now being incorporated into usage-based insurance programs. So what's usage-based insurance? Anyone plug in a device into their car to get insurance rated? So that's sort of the standard model. You basically say, I need car insurance, I go sign up, and you get an invitation, say, hey, we'll monitor your behavior for a certain period, like 4 or 5 months, and on your next insurance quote for 6 month, your next 6-month policy, we can give you a discount, and some companies offer up to 40%. And basically it's rating people based on their actual behavior as opposed to, this is your age and your demographic and marital status. And it makes a lot of sense for the insurance companies in terms of saving costs, has not really been used to drive behavior change. And it measures things that are modifiable, so whether you have a lot of hard braking and acceleration maneuvers, whether you're speeding, and has the capability to measure phone use while driving, and some will actually, the app ones will actually report it, will tell you, but they're not using it in your insurance discount yet. Things that are less modifiable include late night driving and total mileage. But right now there's about 15 million people that are getting their car insurance in the US like this. And in 2023, it'll be about over 60 million people are the projections. So now you're talking about huge parts of the population, and this will really be the main way insurance is offered moving forward. It'll be much more costly to go about the traditional route of of rating. So there was a call for proposals from the Federal Highway Administration for a cooperative agreement, which we were fortunate to get, in applying behavioral economics to reduce cell phone use while driving. And this is enabling us to do very large-scale RCTs on the order of thousands of people now. One in the employer context, which I can discuss later with fleet drivers, but this one's with a large carrier. We've been in negotiations for like 4 months, but something will be public pretty soon. But basically what's going to happen is that people will sign up, they use an app for doing their usage-based insurance. They go through go through 50 days of sort of being monitored for the app, with the app, and eligible for a discount on their next policy. Day 50, they'll get an email from the company saying, do you want you have a great opportunity to participate in a study where you can earn $100 extra for being a safer driver. If you want to participate, and they'll get randomized to 3 main clusters of interventions. One is a nudge to activate the do not disturb while driving, so they have to opt out of it. So basically a couple push notifications to turn it on. So a very simple low touch intervention. The second arm is doing that, but providing some social comparison feedback. So it might be something like on a weekly basis, you get a push notification saying, hey, you used your phone you had about 5 minutes of active phone use per hour of driving. People who are safer drivers and get bigger discounts use it less than 1 minute per hour. And then the third piece is doing that but also providing a loss framed incentive. So they will be endowed with $50 that goes into a virtual account, and then based on how they perform on a weekly basis and their amount of phone use, money will get docked from that, and they'll be provided feedback on a weekly basis on the status of their account. And then there's some slight variations in terms of size of incentive and way of delivering feedback. But then there'll be a post-intervention period where we turn off the interventions and see if any of these behaviors stick. And we're thinking of it's probably going to be an enrollment in the 2,000 person range based. And so anyway, we're pretty excited, and we'll actually be running this summer and hopefully have some results by next year. All right, so another risky driving behavior that causes a lot of morbidity and mortality is alcohol-impaired driving. 10,000 people die per year, so a third of fatal motor vehicle crashes, kills more people in texting while driving, but is sort of less sexy right now. And it affects mainly young drivers under the age of 35, and there's hundreds of millions of episodes per year, but very few of them result in arrest. So, and people are going to keep doing it unless there's like a high probability of getting caught. There's been some good behavioral economics literature on this from Frank Sloan at Duke, who finds like other impulsive behaviors, people who tend to do this frequently are more present biased. But the other kind of key thing is that they're poor planners. Plan an alternative ride or means of transportation, and then there's a lot more overconfidence bias. People think that they're good drivers when they're drunk. So one thing I became interested in is whether maybe testing and seeing if what your blood alcohol content is would affect your behavior. And so there's been interest in this since like the 1970s with personal breathalyzers, putting breathalyzers in bars where you can see where you are. But more recently, starting in 2013, there have been the development of breath testing devices that, like many devices, pair with your smartphone. So now you can track things over time and incorporate feedback based on your blood alcohol content. And so, the question is this a means, is checking your blood alcohol content, is that going to actually reduce crashes? So it was a very rigorous study done by Dr. Oz, in which he looked at some of the common breathalyzers on the market, and it was about the time I was like, okay, what should we use? And really, there was no peer-reviewed data on any of these. So, and then I got one of these breathalyzers and I blew into it after having a couple strong IPAs, and it said I was 0.02. I was like, this is not good. So it actually turns out that breathalyzer was produced by won a Shark Tank competition, and the Federal Trade Commission actually pulled it off the market. And I like this one here. FTC says a smartphone breathalyzer is actually a bunch of bullshit. And so what we did is we collected all the breathalyzers that were on the iTunes and Google Play Store, and we tested them head-to-head in a lab study, which was not hard to recruit for, where we told people we paid them to drink alcohol while we tested these breathalyzers against each other. And so we had a police device as well as these breathalyzers. We first validated against a venipuncture blood draw when we dosed them with alcohol to get them to a target range of a BAC of 0.1. 0.08 is the legal limit. And so what this is showing is like how close in these participants the estimates were relative to the blood draw. And so actually the one that was the closest was the commercial one. It was actually a little bit better than this police one we had to lease for a lot of money. But there were some other ones that were pretty good, and there were some that were pretty bad, underestimating by 0.04. So that's not good. And then when we just looked at relative to the police breathalyzer, so every level, every time that the police breathalyzer registered 0.08, which is the current legal limit, and 0.05, which is going to be the legal limit in Utah. And as part of the National Academies Committee has made the recommendation that the legal limit be reduced to 0.05 because the crash risk goes up even below 0.05. So this one was pretty good at detecting the legal limit of 0.08 and almost 100% of the time 0.05. But these ones like almost never did. And so that's a problem. So this is under review, but I'm wondering what's going to happen to these companies afterwards. All right, so this is the coolest thing I've seen in a long time. So the problem with breathalyzers is that you have to carry them around with you. And so, like after like 40 uses, unless you're really motivated, like there's going to be some drop off. So this group in Pittsburgh basically recruited people out of the emergency department who are high-risk drinkers and put an app on their phone and collect all this raw data and did machine learning on it. And based on things like the time of the day, the motion changes, their emoticon use, they were actually able to classify with 96% accuracy as to whether you were not drinking a little bit, or drinking a lot. Things like lag time in your responses. So if you can imagine, for behavioral interventions that are just triggered and passive based on your phone use, this opens up a whole new realm. So I'm pretty excited about that. Another thing coming down one last thing. There's cool data on the breathalyzers, but the question is whether giving people that feedback actually changes the behavior in the ways that you want it to. So we did a randomized trial in the lab, which we recently completed. I'm presenting at our National Emergency Medicine Conference next month. We randomized 20 drinkers to getting dosed up to 0.01, or 0.1, so like above the legal limit. And then we sequentially took breathalyzer measurements every 20 minutes, and half the group was shown what their blood alcohol content was, and half was not. And then we asked them very simply, how drunk do you feel, and how willing are you to drive on a visual analog scale? So what we found is, the green plot is the control group, and the orange plot is the ones that were shown blood alcohol content feedback. So below this threshold of 0.08, people who were shown their blood alcohol content actually perceived feeling less drunk. And more concerningly, people below 0.08 were nearly twice as likely to say that they're willing to drive up until they got to the legal limit. So there's a lot more work to be done, and I think once you probably get above 0.08, which is hard to test in the lab, like these curves might invert and cross each other, such that you may feel like you're actually okay to drive, and then you see that you're 0.12 or 0.14, and you're maybe change your decision. But like more work needs to be done to figure out, well, people start using this on a wide scale, are we going to have unintended consequences from people sort of saying, oh, I'm actually okay, I can drive now, rather than sort of feeling a buzz and not driving. One other thing that's on the horizon, this company is got a prototype out there. It should be coming on the market pretty soon, where they have an Apple Watch band that can actually detect your blood alcohol through your sweat, the algorithm's supposed to give you sort of real-time feedback. So this is, I'd imagine some of the same issues that we're seeing with the breathalyzers are going to apply here, and I think there's a lot of work to be done in this area. So we're in the midst and about to finish a trial. We recruited drinkers who drive frequently and gave them breathalyzers, followed them for a month, and then randomized them to receiving a text message intervention that was informed by behavioral economics to sort of get them maybe not to drink and drive. And so, for example, like from one of the, and this is sent like at noon on a Friday, so like when they're not intoxicated and can actually reflect on this and plan something. But it would say a BAC of greater than 0.04 impairs driving can lead to failed sobriety test. A DUI can lead to having to blow in a breathalyzer every time you start your car, so that's an interlock device, which is a law, I think, that's increasingly being adopted. Don't lose your reputation, plan a ride, and commit to not driving tonight. So we shall see what happens. I think this will be the first study in which we remotely collected alcohol consumption data and all their driving exposure. And just an example, I just pulled this yesterday from one of the participants. So we can link these data together. So in this participant, we collected 20 trips in which they, over the course of 8 months, in which they had some alcohol and drove around the same time. And so we got the timestamp, for example, this is like right when the study started. They had blew a .095 at 1 in the morning. They're supposed to be sort of below .02 by 7 in the morning, yet they started a trip at 1:53, so that's not good. But here, after, this is in the intervention period, they blew a .07, and then again, they waited a little bit and blew a .062, and then they drove afterwards. So, and that's not ideal, but it's at least like a risk reduction. And so, I think a lot of work needs to be done about what's the right engagement strategies. What can the companies put into their apps that make people less likely to drink and drive? All right, so the last piece I think is probably something that probably more direct relevance to some of the work going on here in Michigan, and I'm focused on ways of encouraging safer opioid prescribing behavior. I think this is not a shock to many of the people here about where we are in the crisis, and so these are all the deaths in 2016. Now we're up to 14,000 deaths from prescription opioids, and much more from like fentanyl and heroin. And on the current projections, it was published in The Economist based off some modeling in Pittsburgh, that by 2025 we're going to be in the range of 100,000 deaths per year unless something dramatically changes. So it's pretty out of control. The other thing that we know is that people that are using heroin or injecting fentanyl, that at least 2/3 of them started by abusing prescription narcotics. So especially for the younger populations, this is sort of a key route for prevention, which is, can you reduce or more safely prescribe prescription opioids? So, and there's a CDC study out there that looks at the initial relationship between opioid prescriptions and long-term use. But I think this is a much better study, and it's actually buried in the back of Michael Barnett's New England Journal paper in the supplemental appendix. What they did is that they took Medicare claims data and looked at whether the doctor that you were treated by in the emergency department, and divided that doctor into quartiles based on the average amount of opioids that they prescribe in terms of morphine milligram equivalents. So, there's some variation in terms of what's being prescribed, even within emergency departments. And what they found was that if you're exposed to like the high intensity prescribers, so this morphine milligram equivalents, that's people that write on average 36 tabs of hydrocodone or 24 tabs of oxycodone 5 milligrams, compared to the lower amount, that the odds of sort of continually being on opioids after being opioid naive goes up significantly. And now say, this is an elderly population, does this really apply? This is a heterogeneous group. I presented a study last year that we're just going through the rise and resubmission phase right now, where we just We looked at Optum private insurance claims, looked at people who came into the emergency department with a single ankle sprain, so a young, healthy group with an injury that is typically resolves within a week or two. So they're not likely to develop chronic ankle pain. I can't remember the last time I saw someone in the ER with chronic ankle pain. And we looked at whether the size of the initial prescription and whether all of a sudden that patient started filling a bunch of opioid prescriptions in the following 6 months. And what we found is that basically there's a dose response, and really sort of the critical threshold is about 30 tabs of oxycodone or 45 tabs hydrocodone seems to be independently associated with this prolonged risk. So the bottom line, ideally don't expose, and if you do, prescribe the smallest quantity possible. And finally, the other big, not just for the people that we're prescribing for, but it's really what we can't measure in claims data, in PDMP data, is the supply of tablets that are in the community. I'm sure there's several people here who've had minor dental or orthopedic procedure who got opioid tablets and probably have some still in their medicine cabinet, just in case. All these unused tabs are ripe for abuse, and it turns out that of people who are abusing prescription opioids are getting it from, at least 2/3 are getting it from other people. So not people that we can measure. So the goal is to reduce the amount of the unused supply of tabs, particularly for acute pain. All right, so what have we done to address this? So we just published this study. I think it's in this month's journal, General Internal Medicine. We had an opportunity when our emergency department switched from our homegrown EMR, which did not have a default number of tablets for opioids, to Epic, to introduce a default number of tablets. So, this got rolled in with a bunch of other defaults for other medications we got prescribed. And what we found, so this is what it looks like. So if I, wanted to discharge someone home on Percocet, I type in Percocet, you get a preference list, and the default is 10 tablets. So I could come down here and accept and sign it, and if I did nothing, that's what would happen. I could switch to the second listed one, which is 20 tablets, or I could go in there and actually change the number of tablets. Or I could go to this database lookup and sort of look at all the different options for that medication. And what we found is that it did dramatically change prescribing. We didn't announce it to anyone. And so the number of prescriptions, proportion of prescriptions for 10 tablets jumped from 20.6% to 43%. And then with reductions in ones from 11 to 19 tablets or for 20 tablets. But we also had this unintended consequence where we actually, because we've been sort of focusing on opioid prescribing a lot in our emergency department, our baseline prescribing rates were low. People who were prescribing lower than 10, like 8 tablets, are now being nudged up to 10 tablets. So we had a reduction there, not a clinically significant one, but still worth noting. But this was concerning here. So the proportion of prescriptions for more than 20 tablets went up. And what we found, only by a small amount, that when people opted out and went to the database lookup, I didn't know about this, but there's a health system default for 28 tablets. So all these ones that went up were actually because they were being nudged towards the health system default. So all these nudges are there in your EMR, just whether you design them to achieve the goals you want. We have a sort of follow-up study. This is joint work with Amol Navathe and Mitesh Patel, who are also with me at the Center for Health and Science Behavioral Economics, grant from the Donahue Foundation, working with the Sutter Health System, where we're doing a randomized intervention with 20 emergency departments and a bunch more urgent care centers where they're being randomized to defaults at the ED level, as well as social comparison feedback. So you prescribe this amount of pills per prescription, and you write this many prescriptions for these sort of standard conditions, then the final arm is using those two together. So that's still in the design implementation phase, but it's in the works. But I think personally, and the data shows us that really there's much more room to move the needle in the post-operative setting. And I know the Open Network here at Michigan's have been doing a lot of work on this. But this review found that the majority of tablets prescribed for surgeries are not taken. And because you're given this prescription from this doctor that you just trusted with your surgery, you don't get rid of it because there's a strong endowment effect there. And it's also inconvenient. And so we want to reduce the amount of unused pills. So I went through our health system data and sort of looked at who are the top acute pain prescribers and saw that there's opportunities with orthopedics. And I went to one of my colleagues and said, hey, defaults worked in the ER. Do you want to try this in orthopedics? And he said, well, sure, but I want to make sure that my patients who are coming to see me from an hour away are not going to have to come back for refills, that they're not going to go to our competitor down the street. So I said, well, I'll have my research assistant call your patients after your surgery and just find out how many tablets they're taking. So we did this for simple knee arthroscopies as well as ACL repairs. And it was very simple, like 7 days after their procedure, they got called. It was like a check-in QI call. And we said, oh, by the way, how many tablets do you have left over of your Percocet? How's your ability to manage pain? And what we found was that the median quantity prescribed, at least for like a simple knee arthroscopy outpatient procedure, is 30 tablets, but the median taken was 4, with a third taking 0, and no more than 20% taking more than 19. And we had this patient who was prescribed 90 that had 89 left over. So I think this is not just our problem. I think it's a common problem. So we implemented an intervention where we use those data and set defaults. And we targeted the defaults around the 75th to 80th percentile so that 75 to 80% of patients would be covered. And there's a smart set specifically for knee arthroscopy. And what we found was that as soon as we turned it on, the median number of tablets prescribed went down by 15. The median tablets left over went down by 20, but there's no quantity in the median taken. People are still taking on average 3 tablets, and 75% were taking no more than 10. And when we assessed, how was their ability to manage their pain, they rated it as actually even better in the period afterwards. And so pretty dramatic shifts. So the prescriptions for 15 tablets went from 8 to 55%. Ones for 30 tablets went from 60 to 22%, and ones more than 40 tablets went down by a lot. And there was no concerns from the patients. There wasn't an increased refill rate, so that was good. We did this for something similar for people who had ACL repairs, more inflammatory condition. And because I didn't mention this, but we defaulted people to getting acetaminophen and ibuprofen maxed out first and separating out the oxycodone. There's actually less opioid tablets taken after these procedures because they're maxing out their non-opioid analgesia. So if we look at the Optum data about how many of these procedures are done per year, so like 54,000 just for this one insurer, if we were able to reduce that variation, we're talking about hundreds of thousands of tablets prevented from going to the community for just one procedure. So how do you bring this to scale? I can't have my research assistant call everybody. So we just got some funding. We have an automated texting platform, which is now people are going to consent to, we're just about to roll it out this couple weeks, where everyone getting orthopedic and neurosurgery is going to consent in the pre-op consent to being texted after their procedure, and we're going to collect the same data. But now we can do it across multiple different procedures, and the end goal is to develop these patient-informed defaults. for these procedures and sort of test the impact. So that's it for me. I have a lot of different people I work with, across multiple different centers at Penn, which is it's kind of like here, is very interdisciplinary and collaborative, and I appreciate you inviting me, and I have that's me on Twitter and my email, and happy to take questions and follow up afterwards too. Thanks. Yeah, a couple things. One is I think we're defaulting people to sort of the standard opioid prescription for acute pain is 5 milligrams of the opioid plus like 325 of acetaminophen, right? But if you want to maximize the dose of acetaminophen, you're not going to do well with doing that and so what we decided to do is default people to maximizing the dose of acetaminophen, plus also taking ibuprofen on top of that. And if they still had pain, then they could take the oxycodones. And so I think that's why we're seeing is by defaulting people to maximize their non-opioid analgesics and then only take the opioids if they're really having pain.
How do you do sort of like operationalize some of this stuff around sort of quality measures for, say, opioid prescribing, which is sort of the last topic here. I'm curious what your thoughts are about that. I mean, certainly like ramping down on morphine equivalents prescribed for acute conditions is one way, sort of, sucking out the excess pills out in the community is one way. I'm curious if you think there are other ways, and in particular, I'm curious about naloxone, which seems to be getting a lot of press recently. Is that sort of something you think is got utility or not?
Yeah, so that's really great. So question about quality measures for, safer opioid prescribing, and then sort of also to encourage the use of naloxone. I think we had to divide opioid prescribing into acute prescribing, so people being prescribed for acute pain versus chronic pain, and their guidelines. The acute pain guidelines, I think that's where we can do the most work, and I think unfortunately there's been the least amount of data. We're trying to contribute to that, but I think what we need is procedure-specific guidelines so that you can measure then whether prescribing is guideline concordant, right? So for the emergency department, we have like a pretty good guideline that says we shouldn't be giving more than a 3-day supply. But for these orthopedic surgeons who are very well intended and want to take good care of their patients, there's not really one that says, okay, for knee replacements it should be this, and for more minor procedures it should be less. So we're trying to provide the data that shows them that if they prescribe that amount, that's what should be taken. It's kind of like antibiotic prescribing. There's evidence-based guidelines on sort of courses, like how long a course should be. You don't want to prescribe everyone the absolute longest course when for most people a shorter course will do. So I think the science has to catch up. With naloxone, I mean, I think should be a guideline on like every patient that comes in with an opioid use disorder or an overdose should be presented the option for take-home naloxone. And so we're defaulting that in our ED. So when we have an opioid use disorder complaint that triggers when people come in with overdose or detox, and it prompts them to consider an order set that has, you screen for opioid withdrawal, and it provides a pre-selected, pre-written order for take-home naloxone.
How do you differentiate for folks with pre-existing conditions that, for example, whether it's chronic back pain, a spinal cord injury, things that aren't here's a healthy adult, but here's an individual with a history of a condition associated with pain or associated with the use of opioids or other?
Yeah, that's a great, I mean, so certainly people who have chronic pain or other conditions are going to have different needs. Right now, we're trying to keep this as simple as possible and including them in this population of data, but we can segment those people out. So that hopefully we can say, here's the guideline for everyone, but if you have this, you know, consider these guidelines.
What role do you think, so first of all, nice talk, this is a really interesting thing. Thinking from a behavioral standpoint, so as a psychologist thinking a little bit about how do we shape patients' expectations prior to a procedure that might predispose them to using less or kind of expecting different outcomes. As an example, I looked at Mass General's website and they were talking about ways to reduce, and so they had this little video where if you come in for a knee arthroplasty in the United States, you expect to have opiates. If you go to Holland, you might go home on periectamol, for example, or, you know, and so kind of shaping, what role does shaping patients' expectations prior to procedures?
Yeah, I think that's definitely a place that we need to go. We have so we have a PCORI study run by Zach Mizell in our department, which is sort of as people are considering writing opioids for pain, they get an iPad tablet that they can select from a 90-second narrative of patients that have been prescribed opioids and have had problems to sort of the sticky narrative that there are risks associated with this. The one that we're thinking about implementing in sports medicine is that we show people, you know, like a simple page when they're leaving the procedure that 30%, you know, took none, you know, very few took more than 10. Where do you want to, or having the patients more engaged, and so once they see that, they say, oh, you know, I'm okay if you just prescribe me 6, you know. And so I think more science is needed, but I think that's definitely a clear pathway forward. I think I'm out of time, so thanks.
I have a gift to present to you from
Awesome.
IHPI. They are IHPA socks, which
Yeah.
you're not familiar with, but probably people in the audience.
Yeah.
Some
Awesome.
before, very high branding. So thank you very much.
Yeah.